So, what are some of your thoughts on how monoclonal antibodies are kind of changing the landscape for adult ALL, and what are some of your main challenges and opportunities in integrating them?
I think in ALL, it has been a success story as well, like in CML. Not so as much as CML, but we're very close. And this is because of the immunotherapy platform we have that being integrated into the frontline setting. And that have shown that such a strategy improves survival. And then as a consequence, we're using less of intensive chemotherapy, less of a complication, and improving survival and relying less on transplant. Because by deepening the responses, we use less transplant and that correlates with a better outcome. The challenge is still like expensive and we need to have a full penetration. I think we're doing quite well in USA, but I hope worldwide we will have the same results too.
Mm. And you've also mentioned things like multi-targeted antibodies and CAR T therapies as future directions. What are some of the most promising candidates currently, you think, in trial, and what hurdles maybe remain for their broader adoption in adult ALL?
Well, ALL is rare disease, and I think to get a standard of care, you need to have a randomized trial. And I think it's not the right time to conduct randomized trial. The field is evolving so fast that if by the time you complete a study, your new standard will become obsolete. So I think as investigators, we need to be smarter and maybe single arm trial, small series, and try to keep improving till we get to the optimal regimen we can have, and then we can randomize our patients. I think in a setting of immunotherapy, what I've seen that physicians use one drug at a time. Yes, you can have some responses, but not too durable. So if you look at the investment done with one drug at a time, you have minimal return and a lot of money spent. In contrast, if these strategies are being used in combination and upfront, you can have a better responses, better outcome, and a better safety. So this is what we're doing today.
Mm. So you've addressed the impact of achieving MRD negativity after CAR T cell therapy in B cell ALL. Based on your, I would say, latest finding, although I know there have been many papers, how do you think MRD status should influence post CAR T management, particularly regarding the need for allogeneic transplant?
Okay, number one, I like to usually put my best effort in the front line. I will not wait for relapse. I think using immunotherapy up front and having an MRD negativity is good for the outcome. And by MRD negativity, I mean going deeper and deeper. For example, today we're using the NGS testing at 10 to minus 6 means patient on a flow studies who are negative, we know 40% of them remain MRD positive. And only if you become MRD negative by NGS, then you will do well. The question is, does that satisfy us or transplant is still needed? I think not all patients are equal. And I think NGS MRD negativity is great, but not so great in everybody because some patients have a very poor biology, like KMT2A disease, where transplant is still needed. Now, that being said, I think the strategy for us today is, can we get CAR T cells into the front line? Where? I think the future of ALL is for the CAR T to replace allotransplant because today, despite the immunotherapy we're using, high-risk patients are going for transplant, and once they relapse, they go for CAR T cells. What I want to do is and evaluate whether CAR T can be given upfront and spare the need for transplant. So you take a patient at high-risk disease who get the inotuzumab, blinatumomab, they go into remission and go for CAR T. This will allow us, if we can demonstrate that it's feasible and successful, to transform treatment for ALL from 3 years to 6 months, with the CAR T being a finite therapy as a consolidation post short induction consolidation. That's what we're testing today. And I think if we're successful, we will cure the vast majority of the patient with a short period of time.
Mm.